And this is the reason why we gather today for this webinar. We have the chance to have 4 expert demographers from various backgrounds that probably, I would say, switch the usual topic of research in the last years in order to provide new knowledge on COVID-19. So the first speaker is Jennifer Bimdahl from Oxford University. In her speech, she will highlight demographic insights into COVID-19, ranging from the intersections of population age, structures, and mortality to estimates of excess mortality. She's the author, I think, of one of the most cited papers on COVID-19 in demography that was published in the PNAS in May. And this paper has already been cited more than 350 times, I think. The second speaker is Tomasz Sobotka from the Vienna Institute of Demography. In addition of age, he will also talk about the importance of gender differentials in the way COVID-19 affects people. The third speaker is Enrique Acosta from the Max Planck Institute for Demographic Research, and he will present us today a database called CoverAge, which provides harmonized demographic data on COVID-19. And finally, the fourth speaker is Samir Kaisi from our institute, the Asian Demographic Research Institute. And from my case study on India, it will introduce the interaction between other social demographic factors, such as education, household facilities, and so on, and the vulnerability to COVID-19. Well, before starting the webinar, because so no one can see each other, I would just want to show you who we are. So I did, sorry, I just need to share my screen to, yes. So this is, we are 85 participants that subscribe, and this is where we come from today. We are mainly from China, Asia, Southeast Asia. We also have people from Africa, about 10, some people in Europe, and some people in America. So I salute the courage of the Americans and Canadians that for them it's 2 or 3 a.m. or yeah, they are very motivated, and I'm very happy to see that people were enough interested into the seminar to stay awake that late. Yeah, and okay, so before giving this, the speech to Jennifer, I will share a video of the director of the Asian Demographic Research Institute that will welcome you and present the center. So it's a 5-minute video, and unfortunately cannot join us in person. So I will need to share the video that I have on my screen. Sorry, I need to wait. Share the film. I hope you see this.
Hello, everyone. It's a great pleasure for me to welcome you all to the webinar hosted by Asian Demographic Research Institute on the auspices of Asian MetaCentre for Population and Sustainable Development Analysis. For those who are not familiar with the institute, ADRI was established in 2015 at Shanghai University, collaboratively with the YASA World Population Program. ADRI applies formal demographic methods and techniques to study important and emerging population-related issues, and carries out comparative analysis across countries in Asia and other regions. In early 2016, ADRI started to assume function as the new headquarters of the Asian MetaCentre for Population and Sustainable Development Analysis. The MetaCentre was established in 2000 as a regional center for excellence in population studies. It is now a large network of population institutes around Asia. In this capacity, ADRI closely collaborates with other principal investigator institutes, including YASA, National University of Singapore, Chulalongkorn University, as well as many other member institutes. Over the past years, we held 2 Asian population forums, hosted the 4th Asian Population Association Conference, and numerous training workshops, summer schools, seminars, as well as a series of joint research projects on migration, subnational population projections, and the socio-ecological impacts of international migration. The pandemic crisis made all the in-person meetings and events impossible during the past years. The novel coronavirus not only interrupted our academic activities, more importantly, it threatens to undo the years of progress in global health and progress in achieving the UN Sustainable Development Goals. To encounter the grave challenges posed by the pandemic crisis, human societies needs collaborative efforts greater than ever before, because the virus does not respect state boundary, and no one is immune from the risk until being vaccinated, regardless of social, economic status, race, citizenship. We need to work cross-country, sectors, and disciplines to co-create solutions to drive engagement and to initiate activities and initiate actions. Demographers could make important contribution to understanding both the spreading and the consequences of the pandemic, and help explore mitigation strategies and inform policy priorities. Because population events, population composition by age, gender, household structure, and population spatial distributions are all directly linked to the infection, prevalence, illness severity, and efficacy of countermeasures. I believe the network and collaboration under the Asian MetaCentre can serve as such a platform to leverage expertise and resources for achieving the impacts that any single institute cannot accomplish on its own. I'm grateful that the four leading experts who have worked and published on the topics of COVID-19 agreed to speak at today's webinar. I want to thank Gil for organizing and chairing the meeting. We are also happy that Maxine recently joined ADRI to help manage the events and other related activities with the Asian MetaCentre. You may receive more emails or interact with her in the future. Thank you all again for participating in the webinar. I look forward to seeing you in person and collaborating with you in the future ADRI and Asian MetaCentre events. Thank you.
Okay, so maybe I will give the, maybe Jennifer will start her presentations. So all speakers will have 15 to 20 minutes. Perfect.
Unmute. Okay, can everybody see that? Yes. Great. Good afternoon. It's morning here in the UK, but I'm really excited to be with you today. This is definitely one of the benefits of reduced travel, is that we can at least visit each other virtually around the world. But I'll say we are quite jealous of all of you in Asia right now. The rest of the world is facing daily life that's very, very different. So no, it's great to connect in this way. I'm going to talk today a bit about the paper that kind of kicked it off last spring for my interest, academic interest in COVID-19, and really just the continued ways in which very simple demographic insights and a population perspective have been important for understanding COVID as time goes by. And I might get to it a little at the end, but I've come at this both through an academic lens and also through a science communication effort that I've been a part of throughout the pandemic. So I've done a lot of trying to interpret all the data coming out for a more general audience. And it's really struck me how important demography has been pretty much at every turn. So this is going to be kind of a broader talk rather than one specific piece of work. Trying to advance. Okay, and this was really what we were all thinking, I guess, back in the spring as new data started to emerge about the pandemic. So like many of you, I guess in Asia, January and February were really nervous months, but here in Europe and the US, we were kind of watching with curiosity, but things didn't really get real until we saw that this was indeed taking off in other countries such as Italy. And that's when the interest turned a bit more academic for me. I saw our center, our demography center here has many postdocs and colleagues who live in Italy and were able to get back before those early lockdowns to be with their families. And so we were in communication and hearing what was going on with them, but we were watching these daily mortality data coming out of Italy. And so, the Lombardy region was hit quite hard. And so these looked pretty similar in March when things were first happening. And I think for any demographer, what would strike you is the real concentration of mortality at older ages. So it's, a very steep association, but also in this case, you can see that almost all the mortality is happening above age 60. And that made us, naturally think about, why is Italy getting hit so hard, perhaps, because it actually is the second oldest country in the world with, I think, about 23% of the population above age 65. And, we were thinking about this in March and writing a preprint. And, I think the same day we actually released our preprint, I saw this on Twitter. And so we really don't take credit for this insight because it was what every single demographer was thinking at the time. Yes, but have you considered the population age structure? So we really were just stating the most demography thing ever, at the right time in March. So we take no credit for this. The paper's been cited just because this simple fact is really important for the pandemic, but nothing, super special that we did analytically. So we can't take credit for that, but it has been, really important going forward. And so the original paper, which first came out in March before most countries had, even been touched by the pandemic. So we were really speculating how might population age structure affect the expected burden of mortality across different countries. Because of this incredibly steep age gradient in mortality that we were seeing coming out of many countries. So we did a very simple exercise with population pyramids where we assumed, I think at the time, a 10% infection rate across the population, which was probably optimistic. We took the published case fatality rates at the time, age-specific case fatality rates from Italy, and then just applied them to the population age structure of different countries to illustrate how, differences. So Italy being a much older population than Korea, even with the same level of infection. Again, an important assumption was also that infection was uniform across age groups, leads to a much higher number of expected deaths in Italy compared to South Korea. You could look at this in countries that differed even more by age structure, Brazil and Nigeria, which have close to the same population size. And you can see that because of the extremely young age structure of Nigeria, translates into a much lower number of expected deaths. And I think it's still really interesting, and maybe some of the people in the webinar will have insights into what's going on in Africa. But in some regards, this has played out in the sense that I think there's a lot of public health preparedness and things that are protecting the African continent, and it might be starting to get worse from things I've heard, but in general, the young demography might be one protective factor during the pandemic. And so, you can really adjust many of these assumptions, the specific infection fatality rates or the percentage of the population that gets infected, but this tight relationship between population age structure and mortality remains just because of the steepness of this age gradient and mortality. And we also looked at 3 different countries here, just a little animation that shows, sort of a middling population age structure, the US, an older population age structure, Italy, and the youngest, Nigeria. And so the greater the prevalence of the infection, those gaps in mortality between, those gaps in mortality due to age structure get even more exaggerated as more and more of the population gets infected. So this really simple point, as I said, has remained important. And I just, since I'm, looking at COVID data on a daily basis and trying to interpret it for lots of people, I noticed this same, issue coming up again and again. So this is current data of cases per million. And you can see that Germany looks to be doing a lot better in per capita infections than the US and the UK. But what I noted was that their death rates were looking quite comparable. So I put just a question out to Twitter and some German colleagues what might be going on here. Of course, I had some hypotheses, but so this is just a couple days ago. The answer that I got, which again is just a hypothesis, but that the hardest hit areas of Germany right now are in fact the oldest. And there's been evidence of really increased prevalence in these very old age groups, including 90 and above. So as the pandemic continues to roll out, this issue of age structure keeps cropping up again and again, both within and across countries. And I wanted to point out another way, very simple way in which age adjustment has been important. So I think another thing that's been surprising during the pandemic is that early on, we were seeing just a lot of raw data coming out of raw death counts and percentages. And this was data from New York City back in May. And someone pointing out that, if you look at the deaths by race ethnicity, it looked like the Hispanic deaths were roughly the same percentage as, the representation in the population. But if you take into account that Latinos are actually much younger on average in New York City, then you would see that there's actually a large disparity in mortality. And so that, again, we do age adjustment in our sleep, but very early on, these were things that we couldn't take for granted and really needed this population perspective and training to point out. And demography, as I said, has really remained central to understanding so much of COVID data. And so I'm just going to give a few examples and how I think it's really important right now, especially with vaccination rollout. One example is trying to understand changes in the infection fatality rate over time. The spring waves happened in the context in Europe and the US of very little testing compared to how many cases we thought were out there. And so as fatality rates started to come down in second waves, there's a question about, is this due to, COVID actually getting less fatal? Are we getting better at treating? Or what else might be going on? And I think, there's a couple demographic things that are probably driving most of this change. Dramatic increases in testing mean that, our denominator is much different in more recent waves compared to what was happening in the spring. And then the second thing is that the age distribution of infection has shifted younger. So not surprisingly, older and more vulnerable people are taking more precautions. As the summer lockdowns eased in Europe, it was definitely younger adults and young people, more willing to go out and take risks. So those things combined were very important. And then I think there is a small part of that where treatment, in hospitalized patients and dexamethasone, there were some improvements in care, but nothing that, dramatically changed how fatal the infection was. And this just shows you how tests per capita have increased over time since the spring in the UK, for example, and how that, translated into a large drop in the estimated case fatality rate. And it's kind of leveling off at still an alarmingly high number. And obviously we're still not catching all of the cases for the denominator, but I think it's really those two things that are driving those changes over time. You can see here some data from England. It's a little bit from back in the autumn, but you can see that compared to what the age distribution of cases in that first wave, it looks like the age distribution in later waves was much more skewed towards young adults. And again, we weren't we were testing only more severe cases in the spring, so it's not directly comparable, but we have some other evidence that suggests this was true and probably driving a lot of these differences in the infection fatality rate over time. Another area in which demography, sort of basic demographic insights have been really important are, trying to understand how dangerous and how fatal exactly is COVID. Perhaps not in Asia, but at least in the US and parts of Europe, there's been skepticism that this actually is not so bad. It's, not really more fatal than the flu, or we're over counting COVID deaths. We're everyone's putting it on the death certificate no matter what people are dying of. These are things that I hear a lot in the communication effort I'm working on. And, demographers have a good way around that. If you don't believe the specific cause of death that's being listed on the death certificate, we'll count every single death, no matter the cause, and compare that to what we would have expected in previous years. And so I think that's, it doesn't convince everyone, but it's a pretty convincing way to get around that challenge of, are we coding COVID deaths accurately? And we've seen excess deaths, really in the US, they've typically been 20 to 40% higher than confirmed COVID deaths. That varies a lot by country. In the UK, they're more comparable. But this is data from just through the summer in the US. And what was really interesting was seeing that the excess mortality really did match the pattern of the movement of the virus across time and space in the US. Because of course, we're interested in understanding whether these are direct deaths due to COVID or indirect deaths, due to avoided healthcare, being afraid to go get healthcare, or of course, the economic and social impacts of the lockdowns themselves. This is only suggestive. I think this will be a very important area for demographers to continue with. But to me, this suggests that, a lot of this was directly due to the virus, since a lot of areas were subject to restrictions in the spring, but the excess mortality really followed the path of the virus across the US. And the Financial Times and lots of other publications have actually done a great job. They're not necessarily using the fanciest modeling ways to do excess mortality that demographers might use, but I think have, to their credit, really brought this concept more into the public eye. And so you can really see the toll of the virus across different countries and across time now by looking at these excess mortality estimates. And so the other important thing that related to the infection fatality rate and trying to understand exactly how fatal is COVID has been, trying to understand this infection fatality rate. And very early on, the question was, is it actually worse than a bad flu season? And I think we were all hoping maybe not, maybe we actually are overestimating this. We were all really anxious to get that denominator right. So that was the real challenge early on, was we knew we were not testing all of these cases, probably only a small fraction and the most severe cases early on. So one thing that's actually been, done, but not as widely as I think it should be, are these more population representative seroprevalence studies. So several countries have that going. The US has not done a good job, but the UK actually has an ongoing ONS infection study that does a weekly random sample of infections, but also in the summer, several countries, including Spain, did nice nationally representative seroprevalence studies to test for evidence of previous infection. And that gave us much better idea of what that actual denominator would be and what those actual infection fatality rates would be. And this is a nice figure that shows kind of combining in the red a lot of different estimates of that infection fatality rate based on seroprevalence studies. And then in blue, the actual infection fatality rates from seasonal influenza in the US from the last several years. And this is on a log scale, but you all can see very clearly how steep that age gradient is for mortality from COVID, even steeper than the flu. And just how many multiples more dangerous COVID is for almost, all ages. You really have to look at the under 20s to think that this is any better than the flu. And so that's great. I think one of the silver linings has been the effects on young children is not serious, but for everyone else, this is a very, very serious mortality rate. The next thing I just wanted to raise about demography and specifically age structure was, I don't know how much press this actually got in Asia, but the Great Barrington Declaration back in October was put forward by three academics, Jay Bhattacharya, Sunetra Gupta, and Martin Kulldorff. And the basic idea was that the most compassionate approach to ending the pandemic would be to what they call focused protection, to really make sure that we keep the most vulnerable groups, the older groups, safe, and then let everyone else go about their business and hopefully build up population immunity. And this very rightly caused a bit of controversy. And first of all, a lot of demographers were weighing in on this idea of how do you actually do this focused protection or shielding of the vulnerable. As we all know, in many countries, the percentage of the population that's above age 60 or 65 is quite large. And when you start thinking about the comorbidities that we know also raise your risk for COVID mortality, you could get up to a very large percentage of the population potentially that needs to be shielded. And there were very little details about how you would go about doing this, how you would deal with multi-generational households, which of course vary a lot across different countries. And so this raised, quite a ruckus. And there were some academic responses to this. And I did just a little back of the envelope about, okay, even in the best case scenario, if we could protect the entire population above age 65 in the US, for example, so no infections or very, small number of infections above age 65, to reach herd immunity, you actually have to get close to 80% of the population, especially if you're protecting part of the population, almost everyone else would need to get infected. So just using the current age-specific infection fatality rates that have converged to pretty consistent levels, that would actually equate to over 350,000 deaths only in the under 65 age. Because even though those rates are much lower than the over 65s, if you have 80% of the population infected, it's going to add up to a lot of deaths. And if there's even a small spillover to those over 65s, it would mean almost 400,000 additional deaths. So in the best case scenario of really good shielding, but reaching a very high level of infections in everyone else, that's almost 800,000 expected deaths in the US. So, our point, and obviously the number of hospitalizations and ICUs would be many multiples of this. And there's ongoing concerns that we don't really know the long-term effects of infection, such as long COVID. Even if there's a very low prevalence of that, if the whole population is infected, that could add up to many, many people who are have long-term disabilities and things that will affect their health and productivity. So I was, obviously, you can probably tell, not so impressed with this, the execution of this potential idea. And, I hope with vaccination now happening in real life that we wouldn't take something like this seriously. But I think the point is, even though it looks like the risk might be lower when you're younger, the middle ages still have, quite elevated mortality. And when you have 80% of the population infected, that's going to add up to a big burden of morbidity and mortality. So it's not just this dichotomous, you're fine if you're under 65, and we should, lock you away for a while if you're over 65. And so the last thing I wanted to touch on was how this issue has emerged again with the discussions about vaccine prioritization. So this is data from England, I believe, not the entire UK, and it's showing the over here the percentage of deaths that are that have happened due to COVID. Oops. And these are also on the left. These numbers refer to how the Joint Commission on Vaccination has prioritized vaccine rollout in England. Which actually is very age-based. And so that's what I'm going to get to. And so you can see going down here that, if you vaccinate, well, everyone age 65 and over have accounted for 93% of the deaths in England. So the idea is that if you can, start with those groups and vaccinate, just a small percentage of the population, in reality, you can avoid the vast majority of deaths. And in the US, the age distribution is actually a little bit skewed younger. I think it's only 80% of the deaths that have happened in age 65 and over. But there's been, a different approach taken there. The recommendations by the CDC were much more to vaccinate younger groups, essential workers. And so there's been this debate about, in the context of skyrocketing infections, what is the best vaccine rollout strategy? And this figure just shows implementing this, proposed order in England, that with very small percentages of the population vaccinated, you can potentially avert a lot of the potential deaths. And so this is the strategy happening in the UK, but not happening as clearly in the US. So it's going to be very interesting to see how this plays out. And finally, a more recent controversy as well with vaccines has been the issue of how to deploy this most effectively. And so some of you may have seen this, that in the UK, the government said it's okay to delay giving the second dose of both Pfizer and the Oxford AstraZeneca up to 12 weeks. Some people in the US were advocating that as well, so that more people could get their first doses in a short amount of time. But there's been pushback there, and it's probably not going to happen. And I've been following this with great interest, because I think this is genuinely a debate where there might not be one right answer. But what I found really interesting about it, and I should say this is because there's generally, the trials showed quite good efficacy after even one shot of the vaccines, but we didn't really follow people to see how long that lasted. But immunologists also believe that delaying the booster shot there's normally longer gaps between first and second doses. So there's some basis in immunology that this would be safe. And if we can get twice as many people their first dose, especially in the context of surging transmission, that could save a lot of lives, even if, for that individual, getting their second dose a little bit earlier might be better. And that's where I see it as a really interesting population level question. So I know immunologists who work on vaccines, and they were like, no, we can't do that. We only tested the 3 or 4 week interval. That's what the data say. And it struck me how, it was such a narrow individual, point of view, whereas, what we're used to doing is saying, okay, but mathematically, what happens if we get, we still have high efficacy of one dose and we get that to twice as many people in the same amount of time? How does that affect the population level infections and deaths? And so I still don't know what the right answer is. I think it's a gamble either way, but I think it's really interesting where the people saying, no, we can't do that, the science in the trial was only saying this, is kind of, not looking at that big zoomed out population perspective. And so that's something that our discipline, I think, can really bring to these policy debates. So yeah, in the end, this extremely basic demographic insight about age structure continues to be really important in thinking about the implications of the pandemic. But as we heard in the great introduction, I think demography is going to be really important going forward as well, thinking about the long-term social and health consequences. I'm very interested in population health and mortality, thinking about how this will be a scarring event for future life expectancy. There's all sorts of questions for which demographers are going to be the best people to weigh in. So it really, unfortunately, probably will be a golden age of demography for many, many years to come. And I just at the very end wanted to tell you about this science communication effort that I'm a part of. It just happened because we were being asked by a lot of family and friends back in the spring to answer questions about COVID. So got together with a bunch of colleagues, and it became this effort on various social media platforms called Dear Pandemic. So if you're interested in checking that out, we're on many different social media platforms, and we kind of try to answer translate the science into more practical things, and also posts about excess mortality and how to measure that have actually been really important or popular on these platforms, I think, because people are hungry for a way to argue and explain with their family members who are saying this isn't really that dangerous. Yeah, just to say that it's great that you all are, the center has been created and is providing these opportunities for demographic training. And I think it's going to serve everyone well going forward, given the importance of population science for the pandemic. So thank you very much.
Thank you, Jennifer. I think if it was live, you will hear people clapping in their hands, but now it's a bit difficult. So just imagine people clapping now. So before passing to the next presenter, we'll just, for those who have questions or comments, just keep it for later. So once everyone is done with the presentation, we will take comments and yeah. Okay, so I will invite Tomasz to share his screen.
Hello, good morning, good afternoon. I hope you can now see my screen. And what I will be speaking about the next 15-20 minutes would be looking at the age and sex disparities in coronavirus infections in Europe. So I will be essentially following up also on some of the messages which Jennifer was conveying about the importance of age, but also gender or sex dimension in the coronavirus pandemic. Let me see, I cannot somehow move my presentation. No, okay, now we go. So I don't need to repeat some of the messages from Jennifer's presentation. Just to emphasize that actually there are two key dimensions to consider when thinking how the infection is striking the population with respect to age and sex. One possibility which has been stressed a lot by Jennifer is the importance of age and sex composition of the population. So obviously the elderly populations get more affected because there are more elderly people out there, everything else being equal. But at the same time, there might be differences in age and sex patterns of infection rates. So that's something I'm going to discuss much more in detail later on. So irrespective of the actual population composition, there might be populations where more younger people or more women are getting infected and the other way around. I also argue with my colleagues, and this is a collective work with 4 of my colleagues from the Wittgenstein Center, that the age and sex pattern, the age pattern has been studied a lot, but the gender differences in coronavirus infection rates, but also the gender differences in COVID fatality rates or mortality rates have not been studied as much as the age pattern. And we think that gender disparities are very important, in part because the research has shown that there is huge excess mortality, especially among males. So males have up to double the likelihood of dying once getting infected with the coronavirus, controlling for age. As we know also from the previous presentation, the true underlying infection rates are unknown. So that's a clear challenge when studying the infection rates by coronavirus. One possibility is that they can be estimated with sero studies, but these are in most countries limited in scope. And in most cases, they don't allow us to disaggregate population by age and sex because of relatively small samples, which are studied in most cases. So the reported COVID-19 infections, and we call them also confirmed cases or reported cases, are therefore affected very strongly by the frequency of testing. and by the selectivity of tested population by age, sex, occupation, sometimes also region, racial and ethnic groups and other characteristics. In some populations, there has been a lot of targeted testing of some population groups, risky occupations getting tested more, having more access to testing than other population groups. And more important, or moreover, the selectivity in testing can change over time as testing patterns, the availability of testing, capacity of the system, and testing strategies are shifting. So in most countries, we have seen very limited testing during the spring, during the first wave of the coronavirus pandemic, and there has been much more frequent testing since then, especially now during the second wave of the pandemic in autumn and in winter. Now, to give you some idea about how the reported cases may diverge from the actual number of people who have been infected in the population, consider a couple of seroprevalence studies which have been done on a larger scale population. Spain perhaps has had the most comprehensive rounds of sero studies. In spring, in early May, a first round of seroprevalence study in Spain found that 5% of Spanish population had been infected by the time by COVID. At the same time, the reported number of cumulated cases at the time amounted to just 0.5% of Spanish population. That's just 1/10 of those who had been actually infected at that time. Now zoom in towards the second wave. In late November, the fourth round of sero study in Spain, combined with the previous studies, estimated that 10%, 9.9% of Spanish population had been infected by late November cumulatively. So that's spring and autumn wave combined, whereas the reported cumulated cases in late November amounted to 3.5% of Spanish population. So obviously the testing capacity increased over time. So testing was able to catch many more of the infected persons in the second wave. About 3% out of the 5% infected in the second wave were catched by the testing, but still testing never catches all number of infected cases. Similar statistics to the first wave in Spain. In Sweden, a sero study conducted in mid-May found that 6% of the population were actually infected in Sweden, whereas the reported number of infections was much, much lower, just 0.3% of Swedish population. So we are dealing really with somewhat deficient data, and I'm happy to discuss more of these deficiencies and biases later on. Nevertheless, we collected data on age and sex distribution of reported infections in Europe during the first and the second wave. And we looked at 7 different countries, I will show you later on. And we have 6 basic questions which we are trying to address with these data. One, perhaps the key question, are men more likely to get infected than women? Does the gender profile of infections vary by age? And which age groups are most likely to get infected? Are these patterns similar across countries? And how are they moving over time? And whatever we observed, is this supported by testing and seroprevalence data, which, however, are done in a very few countries in such a comprehensive manner that we can really test it. Now we think that probably we can study the male-female differences in infection rates even with relatively biased data based on limited testing, as long as men and women across different ages within each age group have relatively similar likelihood of getting tested. So even if testing catches only, for instance, 10% of the infected population, as in the spring wave in Spain, if men and women are as likely or as unlikely in each age group to get tested, perhaps we can find some true patterns of male-female differences of the sex ratio, sex differences in infection rates. When I refer to infections, reported or registered infections or confirmed cases, I will be speaking about the same things, the officially reported numbers or rates of infections in the population. So we collected this data by sex and age in 7 different European countries. Our data stretch up to mid-November in all these countries. We need to make an update now to capture the whole year 2020. And we look at 10-year age groups up to 80 plus or 90 plus. There are different formats of data published in different countries. In some countries, we were able to access individual data on infected persons. These are the countries where you see ID next to country name. In some countries, we were relying on officially published reports, weekly reports, or reports done in irregular intervals, which we then try to reconstruct to somehow reconstruct monthly patterns of infections. This is a snapshot of our 7 countries and the reported number of cases, which by mid-November amounted to between 1.6% of the total population in Italy, up to almost 5% of population in Belgium who were reported to be infected by mid-November. And interestingly enough, in all these countries, the reported number of cases were more common among women than among men. So the male-female ratio of the numbers of infections were skewed more towards women. What we show as a basic or use as a basic measure of looking at infection rates is that we relate everything to a given population by age and sex. So our main indicator is reported infection rates per 1,000 people of a given age or sex group. And we use these relative reported infection rates to construct relative male-female ratio of infection rates by age and month. And also we look at relative ratios by age. So we look at the overall infection rates, for instance, among men and women, among the total population, and then relate infection rates in each given age group to this overall infection rate to find out whether a given age group is more likely to be infected according to the reported data than the total population of men or than the total population of women. We look at how these profiles change over time by reconstructing monthly data, and we also look at heat maps, which show how these trends change in different age groups and countries. Now, Jennifer mentioned that a lot in spring, there hasn't been so many reported infections as in autumn, just because the testing capacity was so low. So when one plots reported infections in our countries, and the November data are incomplete here, you see a picture which is not really corresponding to how the pandemic was progressing, but you see that a lot of cases have been reported in autumn with higher testing. So now let me get through some of the results in the next 10 minutes or so. This is an illustration of how our data look like when we plot them by sex and age, looking at infection rates in the Netherlands. And this country is pretty typical of the pattern we observe in many other countries. This is a cumulative picture from the start of the pandemic until mid-November. And we see that especially for women, there is a kind of peak at younger ages, and throughout the productive ages, about 20 to 60, women have higher reported infection rates than men. Then suddenly infection rates plunge for women after the age of 60, roughly after retirement, and then they go up again, but in a similar way as male infection rates among the older population. So when one looks at how this male-female ratio in infection rates look by age, typically at the younger ages, there are more women infected, and you see this red area showing that male-female ratio goes below 1. And above age 60, typically there are more men who are infected according to the reported data, at least at ages 60 to 70 or 60 to 80. And this is the pattern we observe in each and every country, although with a different magnitude. So when we plot this male-female ratio in infection rates by age, we observe that in each and every country, with a slight exception of Italy at younger ages, between ages 20 and 60, women are more likely to get infected according to the reported data. And this crosses over after the age of 60, after retirement, with male getting more likely to be infected between 60 and 80. This is, however, shifting over time a little bit. So when we look how this is changing over time, I will have a look at it later on. Now, this picture shows how the age profile of infection is changing over time according to the reported data. When you see red here, and this goes from the highest age group in the upper part of the graph to age 0 in the lower part of the graph. On the x-axis, we have time scale from March to November, which is monthly data. When you see red field, this means that this age group is much more likely to be infected according to the reported data. The blue color shows much lower likelihood of infections. Now in spring, testing was very limited and was probably limited especially to the more severe cases. So there is no surprise that the infections are concentrated among the older age groups. However, we also know from many countries that actually older age groups were hit hard in places like Belgium because the infection was raging in care homes and in the establishments with a lot of elderly people. Now, the summer changed everything. In the summer, it was the younger people who were getting infected much more. And this is a picture typical for each and every country we looked at. Whereas the elderly population suddenly had a lower chance, lower relative rates of infection. So the overall infection rates in the summer were low. And then in autumn, as the pandemic started picking up again and infection rates increased all across Europe, again, there was an increase in cases among the elderly population, unfortunately. So we have some dynamics of age over time. When I go back to the age structure of the infection rates, age distribution of cases, what we observe overall is that the female dominance at younger ages is more or less prevalent across the two waves of infections, with some interruption in the summer in some countries like in Italy and also in Czechia and some other countries among the younger age groups where more men were getting infected at younger age groups. But as we move towards the second wave of the pandemic, women start dominating again the infection rates, although not as much as in spring, in productive ages, especially 30 to 60. Whereas at older ages, 60 to 80, you see a lot of blue fields. That means that males are dominating the infection, the picture of infection profiles, not after the age of 80, however. When we look a little bit more how the age distribution was shifting, the shift towards younger age groups becomes very clear over the summer. For instance, you can, for instance, look at the share of reported infections among the population below the age of 40, that's the blue line, and that really shoots up, peaks around July and August, and then it starts going down again. So the spring data may not be really representative, but we believe that the summer picture, the shift in infections towards young population who had been more mobile at the time, you can think of all the travel, parties, whatever else young people may be doing with less restrictions over the summer. But however, as people return from summer holidays, as schools opened, as life started returning back to normal in many countries, the share of elderly people was increasing again with the infection rates, and the share of younger people with the infections declined And this is a picture which is consistent across most countries, which you see also in this graph, which shows you the mean age of reported infections. Very high in spring, partly because of the selectivity of testing, going down below 40 in each and every country by August, but then going upwards since September on. So unfortunately, in the second wave, the infections had started hitting the elderly population once again with an increasing intensity. Now, are our findings really supported by some other data, which would be kind of confirming that whatever we observe with the officially reported data on infections is really pertaining to total population? And the jury is still out because we don't have really good quality of seroprevalence data for many countries. This is the example of the Spanish survey from late November. And this is the share of population by sex and age who have been estimated to have gone through the infection. And you see that from the ages of 25 up to the ages of 59, there is a slightly higher prevalence of women in the total, in their share in the total population of infected. However, this is non-significant in most of these cases, and the gap is not as big as we observe from the officially reported data. So we kind of see the pattern which we find from the reported data, including the crossover in male-female infection rates around the age of 60. But the evidence is not really conclusive. The same goes for the testing statistics, which we have available for a couple of countries. We know that there is a higher frequency of testing among women than among men aged 20 to 59, which could partly explain why more women are reported to be infected at that age. At the same time, we also know that there is a lower test positivity rate among women, which seems to go against our findings that women are more likely to get infected. But however, we don't know how much this lower test positivity pertains to the fact that many more women than men are tested at these ages. So we think that the evidence is not always fully supporting our findings and observations, but we cannot really conclude much. If we would trust our findings, especially about the gender profile of infections, we think that this has to do something with the structure of female employment and occupation, because most European countries we study have high female employment rates, and women are very strongly engaged in healthcare and social care professions, also in education, where they account for a big majority of professionals. So they are on the kind of front line of exposure when working with ill patients in care homes and in other establishments. Crossover at older ages, we have a different story to explain it. We think that these disparities and the higher prevalence of males at ages 60 to 80 may be explained by the higher severity of infections among older males. So because severe cases are more likely to be detected as these men are hospitalized or have health issues, so are more likely to get tested. We also think that the shifts we observe between the first and second wave are real and reflect the real changes in the age profile of infections, with unfortunately vulnerable populations disproportionately affected in spring and increasingly affected in October and November during the second wave. So the take-home message from our examination is also that countries haven't been successful in shielding or protecting the vulnerable groups of the population, with a lot of outbreaks in hospitals and care establishments in each and every country where infection rates increased over time. And one example is in Belgium, where the cumulated reported cases among population age 90 plus reached 15% of women and 12% of men, versus 4 and 5% in the total population. So even with the kind of biased way of testing and reporting, these are really huge percentages, huge shares of total population. We still need to gather a little bit more evidence on whether the observed patterns are real and are supported in some other data. And we plan to extend our analyses to cover the whole year 2020 and then try to get this discussed and published in the future. Thank you very much.
Thank you, Tomasz. Enrique, please. It's your turn.
Yes. Okay, good morning, everyone, and good night and all time zones. I'm very pleased to be here, and I'm very grateful to the Asian Demographic Research Institute and to Guillaume for the invitation. I'm going to present some indirect measures for adjusting COVID-19 demographic data. And these measures are conceived to complement the Coverage DB project, which is a global demographic database of COVID-19 cases and deaths. And so I will start by describing this database, and I will comment and discuss some of the limitations. And based on and reflecting on these limitations, I'm going to present some simple examples of what complementary measures can do and how to measure and assess the quality and the reporting of data. So I think Thomas and Jennifer have already presented in a very clear way the influence of age and sex in the risk associated of death from COVID-19. So at the beginning of the pandemic, we were also working in presenting a method who was just applying Kitagawa decomposition for comparing case fatality rates across populations. And for doing that, we needed information on age, very detailed in each population. So we went and looked for this data, and despite we found abundant sources of data related to COVID-19 since the beginning of the pandemic, and here we have some examples. The information by age was very scarce and almost inexistent in a centralized manner. And so we went there and looked for different sources, and we found three main challenges to obtain this data disaggregated by age. The first challenge was that each source, each population has a different source for obtaining this data, different websites, and you have to go through each website and try to figure out and navigate where to find this information. And if you are lucky and you find this information, the diversity of digital formats, it's amazing and even creative. You have PDF reports, dashboards, databases, and all different ways of having this information. And the third big challenge is, as Thomas already said, is the different definition of age groups, and this is an obstacle to make clear comparisons across populations. All these challenges are translated in huge cost in effort and time for researchers to perform analysis, taking into account demographic variables, and a lot of redundancy of work. If another research wanted to perform similar analysis, has to start the whole process again and incur in this cost of time and effort. So for this reason, we created and we started the project of Coverage TV, and the aim of the project is to offer a global data database that includes information of age and sex in a centralized source. We include 4 variables so far: cases, deaths, tests, and vaccination, that it's quite recent. And the idea, one of the main advantages of the database, is that it already harmonized age groups using modeling techniques. Also, we complement the database with metadata and definitions documentation, so it can inform better the analysis and give some awareness about what can be compared and what are the obstacles in these comparisons. And one important aspect of the database is that it's constructed under the principles of open science. That means that the access to the data is free and very easy on the web. All the process of transformation of the data is transparent and reproducible. So we have also a GitHub in which you can find the whole code in case you want to judge by yourself if the harmonization process is correct or not. And of course, also to interact with us and we can discuss how to improve these processes. Also, we offer some guide with examples on how to process the data, but also how to merge this data with other sources like population exposures and other sources of like awarding data and complementary data that can help for the analysis. The data collection process happens in both ways, manual and automated, depending on the source. If there is like reports in PDF or dashboards, most of it is manual. Databases are easily automatable. And this implies a huge amount of work, and this project wouldn't be possible without the help of a network of more than 70 collaborators of all academic levels and distributed around the world. The process and the database is coordinated by Tim Rife and myself, and we were very lucky to have a new member of the team as the database manager. That is Jessica Donsowa, that joined us in the last month, and this is happening and hosted at the Max Planck Institute. The coverage of the Coverage DB so far as of today is 110 countries, and within these countries we are collecting data in more than 370 subnational divisions. All this adds to more or less 60% of total cases and deaths that are reported worldwide. If we look at the map at the right, we see that the countries in black are the countries that includes both national and regional information. The countries in purple is the countries that in which we only have information at the national level, and in pink are countries that in which we already identified the sources, but we haven't started to collect it, but will be incorporated very soon in the database. Looking at this map, it's clear that we already have virtually covered all countries in the Americas and also in Western Europe. And we are still in development, of course, and we are focusing in finding new sources in Asia and in Africa and African populations. And we try to be very forward on it, and I think it's the most important thing when using the database and also when constructing the database is to take into account the huge limitations that we have using this data. And the main limitation, of course, is the huge difference that data has across populations. One of the main differences is in definitions of what is a COVID case, what is death, what is test, and what is vaccine. It's a suspected case, is what is the test that is used to confirm, how do you measure the death, and for example, now with vaccines, there is new challenges. It's the first dose, second dose, or it's a different kind of vaccine that only needs one dose. So this kind of differences are very challenging when comparing the data. And also, of course, as Jennifer and Thomas already mentioned, the testing coverage is determinant for the identification of cases and deaths. So this is also a variable that is very important to take into account. So we have three main recommendations to not avoid these limitations, because it's almost impossible, but to inform and to be better prepared and to take them into account. So the first one is to revise very carefully the metadata and the documentation, not only in the database, but also in the sources of the countries that you are using. The second one is to triangulate information. It could be done with different qualitative information and other analyses that are published. Also to merge and triangulate with other databases. There are other databases that have very important information. That is the case of INET database on mortality, or awarding data, or the short-term mortality fluctuations database. And another part in which I want to focus now is the possibility of making adjustments and contrast wherever it's possible. And when I refer to this, I refer exactly to indirect estimations that we plan to include very soon in Coverage DB to put them available for users. And I will focus here in two main measures: is excess deaths from all-cause mortality that can be contrasted with confirmed deaths, and also infections estimates from indirect methods. So I will present very superficially what we or how we are estimating the excess mortality, and what kind of analysis can we do to contrast, or what are the differences that we see in a first sight. So we are using weekly all-cause mortality. This is coming from the short-term mortality fluctuations database that is also from the Max Planck. And of course, I'm lucky that I don't have to go very deep into this. I think, as Jennifer said, most people now are more familiar with the concept of excess mortality. And the idea is to measure the excess from a baseline mortality that is supposed to be in the absence, or a counterfactual scenario in the absence of COVID-19 pandemic. So the idea is for estimating this baseline mortality, we fit a Poisson model to summer weeks. And this Poisson model has three main components: one component that controls for secular change of mortality, a second one for seasonality changes, and a third one for changes in population age structure. So this is an example of Spain between 2010 and 2020 for two age groups, 20 to 24 at the left and 80 to 84 at the right. And the black line shows death rates, weekly death rates. And the blue line is the fitted baseline mortality. As you can see, it's much more harmonic and much more accurate, we could say, the fitting and the estimation of the baseline for older ages. There is more clear seasonality, and also there is much more numbers of deaths, so it's more accurate, the kind of estimations that we can have. And here we can see in the red band the moment when the pandemic struck the hardest in Spain in the spring. And we can see in contrast that for younger ages, the behavior was very different in mortality. Instead of having excess mortality, we had a deficit or a drop in mortality. And there are different causes that I'm going to discuss later. So once we estimated excess mortality for Spain, for the whole population, as of December 20, 2020, we identified, there were reported officially almost 50,000 deaths, but when we look at the excess, the estimates gives around 85, 86,000 deaths. That means that there is 73 higher excess than confirmed deaths for the case of Spain. If we reproduce the same or apply the same analysis to different countries, these are the estimates for 8 countries in Europe. We have Spain, France, the Netherlands, England, Belgium, Italy, Switzerland, and Germany. And we can see that the behavior and the difference between confirmed deaths and excess is not, it doesn't have the same pattern everywhere. And I just forgot to say that I am using these countries because are the countries, some of the countries that were hit very hard during the pandemic, and also the countries for which we have more information of weekly deaths by age. So we can see what are the differences in females versus males, and this is the ratio comparing the excess to confirmed deaths. And we can see, like, surprisingly, even if males have considerably higher mortality than females, it seems that the ratio is higher for females in the case of excess mortality. And other countries, for example, Italy and Belgium and England, seem to have very close confirmed deaths to excess mortality as of this date. And in other cases like Switzerland and Germany, excess mortality is lower than a confirmed case. And of course, as Jennifer also highlighted, there are several publications, not just in the scientific literature, but also in the press that are doing this kind of estimates and are updating this on a daily basis. So the thing that we are highlighting here is to go deeper and to look at the demographic aspects of this in related to age patterns. And what is this age pattern with each country? So we according to literature and with the things that we already know that could happen affecting mortality at different ages, we expect two different patterns. One for young ages, in which we expect low excess, as we saw already in the plot of Spain for age 20. And this is given because, of course, there is a much considerably lower risk of death from COVID-19 compared to older ages. And also there is an important reduction of external causes of death during lockdowns, at least in the countries where this is happening. The opposite would be expected for old ages, a huge or considerably higher excess mortality, of course, because there is an increased risk of death from COVID-19, also because there are some misclassification of deaths in the presence of comorbidities, and also because it could be happening an increase of mortality due to the saturation of the health system, or because of fear of going to the hospitals and continuing treatments during this period. So here present both confirmed and excess mortality in the case of Spain for females and males, and this is the death rates for both. And we can see, for example, in the case of females that indeed young ages have a lower excess mortality than confirmed deaths, and there is a crossover around age 50. And in the case of males, there is much more fluctuations for younger mortality, but we can see also that there is a crossover around age 60 for males. And in both cases, at least in the case of excess, the pattern is much more stable and less fluctuating at older ages. And we can also see this, and we can translate this. Another way to see this comparison is, again, as a ratio of excess to confirmed deaths by age and sex in Spain. So the horizontal line, the dashed line, is when both are equal, confirmed and excess mortality. And I add this vertical line, the red line, just to make the difference at age 50, and just to see again and in a different manner how ratios are much more fluctuating and stable at younger ages for both sexes. And after age 50, there is like a clear pattern of increase in the ratio of excess to confirmed deaths for both sexes. And again, we can see how for females, this ratio is a bit higher than for males. If we look at the same pattern for across the countries that we were already mentioning, we can see and we can identify a similar pattern of important fluctuations in this ratio at younger ages. And there is more stability in the ratio at older ages. And this is the case in most of the countries that are under analysis. However, even if it is a bit more stable, the pattern of ratios at older ages, that doesn't mean that it's the same pattern, and we can identify two groups. One first group in which the ratio of excess to confirmed deaths increases over after age 50. That is the case of these 5 countries, but we have another different pattern, very different for these 3, Belgium, England, and Germany, in which there is not a clear trend over age in the difference between excess and confirmed deaths. So there are many things that can be explored here and would have to look in detail at each of these countries. What is the dynamic of the epidemic at the local level, and also what are the conditions and what is the fitting of the excess mortality and many other things. But here is just to show what kind of difference can be perceived and what potential analysis can be done starting from this point. A second part that I would like to explore right now is regarding the infections. And for this, I'm going to apply this method that was very recently published by Bock-Evold and colleagues, and it's a demographic scaling model for estimating the total infections in the population. And this method is based on a very basic formulation of the infection fatality rate that, in contrast with the case fatality rate, in the denominator doesn't have the confirmed cases, but the total infections in the populations, both confirmed and undiagnosed infections. So we have, if you have deaths and infections, we can easily arithmetically estimate the infections of the population just by obtaining these two data, the deaths and the infection fatality rates. And as already Thomas highlighted, there are several estimates of infection fatality rates, and one of the most comprehensive is the case of Spain, and we have both data for this case. So this is a publication and that appeared very recently, also based on the serological analysis of Spain, and they compare with excess and confirmed deaths. This is the infection fatality rate based on confirmed cases. Now, the problem with this is how to translate and how to move or to impute these infection fatality rates to different populations, because of course, infection fatality rate by age would vary across populations given the health conditions and other variables that are related with the comorbidities, or also the different kind of conditions that can make more vulnerable populations that are more vulnerable to others in this regard. So for this, I think it's the most important part of this method. The more interesting is the adjusting of these infection fatality rates to other populations and just translating the age-specific infection fatality rate to the equivalent age with the same remaining life expectancy in the other population. And this would, in theory, take into account some of the difference in the health conditions. Of course, there are limitations and there are things that are not accounted here, but at least I think it's a very good try to adjust for this difference across population. So here I plot the infection fatality rate adjusted for these different countries, and you can see that it's almost identical and the differences are very close because, of course, these populations have a similar age profile and health profile in the population. But of course, if we include countries like low-income countries, the difference would be much more evident. So from this, we can estimate the infections, and here I go straight to compare what is the ratio of the scaled infections to confirmed cases. And we find here that, for example, in the case of Spain and Italy, the infections that are estimated using this method are, as of December 2020, more than twice than the confirmed cases. And in Germany and Belgium, there is also like between 2 and 2 times higher infections than confirmed cases. However, there are countries in which the cases are higher than the estimated infections. In Switzerland, for example, although it is inside the confidence interval, but for example, Netherlands, that it's much lower. So this model or this methodology has, of course, to be maybe adjusted, including additional information and looking at very specific cases. And again, what is interesting here is also to look at the age distribution of this underestimation or this ratio between infections and confirmed cases. And I plot here the difference across countries. I use 6 countries for which we have both cases and estimated infections. And there is a common pattern of very low ratio at ages 20 in most of them, and there is an increasing ratio at older ages. That is some kind of surprising, because at the beginning the idea was that most of the underestimation was happening at younger ages because it was the asymptomatic cases, and most of the testing was happening in the critical cases that were located at the old ages. However, this is the picture at the end of the year, and we know that testing strategies have shifted toward young ages. So maybe that is what explains this pattern over age. So I would like to make a couple of final remarks. The first one is that more than nothing, this database is a potential for further analysis from your side. We are convinced that the best analysis based on this data are still to come, either comparative analysis, assessment of data quality, or developing new methods for data adjustment and analysis. And the second remark that I would like to do is a call for your collaboration, and mostly regarding source tips. For example, in the case of China, although it is marked as black in the map as having national and subnational data, the data at the national level is just one point in time in February 2020. It's almost a year already old, this data. And at the regional level, we have data more detailed and a longer time series for Hong Kong. So if there are tips or there is information of additional data that can be collected by us, please let us know. Also, if you know of new countries and subnational data in the case of Asia and African countries, also it's very welcome. And we are interested in any data by age, either cases, deaths, and vaccination. That's all, and thank you very much for your attention.
Thank you, Enrique. Samir, please, your turn.
Thank you. See screen one, share. So do you see my screen? Guillaume, do you see my screen?
Yes. I'll fine.
Okay, good. So thank you everyone for joining. I think I'm part of the host, and I see we have almost 30 minutes left. So I will not take too much time, and a lot of things that I needed to say was already said. So it's a very nice kind of a base for me. Unlike other presenters, my work on the COVID related research kind of got stalled around June, July when we submitted this work to +1, and it took almost 6-7 months before they said, we cannot publish this. So we didn't do much between that time, and once we got the comments and all, we are now thinking of actually doing another paper that would be more like collecting lots of other information for the last 6 months regarding defining the population vulnerability to COVID-19, but also lots of papers needs to be included in the future work. So this work, already in March, April, when the cases in South Asia was very, very low, and when there was a first case was identified, there were lots of kind of a commotion about what's going to happen and who are vulnerable and all this. So we started our work then, first in Nepal, and then my colleagues from India, Rakesh Mishra, Raman Mishra, and Ankita Sukla, they kind of approached me and said, let's do something for India. And this is what is what I'm going to present about. So I mean, I don't need to say much about the background. What we thought, or what our thinking process at that time was that, when the COVID started infecting people and killing people, we see that the medical and the public health workers were at the front line, and they were focused on, how to cure, how to kind of, mitigate the effect, and how to save lives and all this. Whereas the rest of the government and the population were thinking like how to prevent from getting infected. and the social distancing, wearing masks, washing hands, and all those things were being put into the media and everywhere. Yeah? What we did was we said, okay, let's start in a country. What would be the who are the vulnerable population? Yeah? And we already started getting information about that age is important and to know, like we already saw in many of the presentations, and what other factors could be important in identifying the vulnerable population. And this is where we started at the community level. And when I say community in this exercise, we took districts as the community, which is still quite large for India. And there were around 640 districts in our data. Actually, in real term, I think there are more than 700 now. So India today, when we see India's reporting from the WHO, there were more than 10 million confirmed cases and about 150,000 deaths. It's quite big. I mean, quite prevalent in India. I mean, the country is as well big, so I should be reporting in terms of population, in terms of rate here. But this is what I got. I just downloaded it today. And so this is a population, the special map about the distribution of the COVID reported cases. So these are the reported cases in India, and all these the borders that you see here are the borders about the districts, and you will see that some very dark colors are here. Representing like Mumbai, like big cities, around the big cities, around yeah, and Calcutta and Bengal and all those areas. So this is just a map of India that we Raman Mishra prepared. Just give you an idea about India's distribution. So we started to define the vulnerability, population vulnerability to COVID-19. We, this why it is important. So at that time, and still, I think now it is more important for the vaccine distribution. So maybe less for defining the vulnerable population in terms of infection, but more in terms of vaccine distribution. But at that time, we thought that this providing this kind of vulnerability map will help the government, to be prepared for what might come. That is, to set up medical services in terms of isolations, the ventilators and ICUs and all. And at that time, Government of India also had categorized district into 3 zones, like red, green, and orange. But it was done in a very simple way, simply, in case just looking at the number of cases, and was not considering any other factors. So we thought that, like providing them more data, so more information, so the more factors that kind of help them identify those places where, the hotspots more clearly. We propose this community vulnerability index. We call it COVID CVI. So the first one was age. So as a demographer, so I don't have to say much here. Age, everybody found that it was very important. So at that time in India, the median age of infection was about 51 years, and 75% of the COVID-19 death in India among patients was happening among patients is 60 and above. And we also know that age is important in terms of that older age people were having the level of severity was higher, but at the same time recovery time was also higher. So those who don't die, the recovery time was higher among them. So it is important to identify places where there are higher number of older adults. So we define 50 plus as the definition for the older adult. And for India, the projection of the population at that level was not available. So from 2011 census, actually India took a long time to do any kind of projection. I think just recently they published their first projections using the 2011 census, but we already had a model for the state level projection. So we used those existing models and data, and with more additional data at the district level from 2011. So the age sex distribution up to 2011 was projected to 2020 because we needed to know how many people are there in 2020. And we find that some higher in the big cities and South India, there are like a higher concentration of the older people. So this is a map showing the distribution of projected population is 50 years and above in India. So it's just in a pure absolute terms. Yeah? So we can see that these areas, like most of those areas, I mean, as an Indian, if somebody, I'm from Nepal, by the way. So this somebody from India would know like what these places are, and these are like areas of Mumbai and Greater Maharashtra or Greater Mumbai areas. And then we have the Bengal area over here. I think this is Bangalore. So I miss my Indian colleagues here. But this is the first map, just showing you where the population, the 50 years and above population are situated. So the second variable that we thought very important, it's all based on what we were reading from the data and the literature coming out, that comorbidity, that being old and having having a health conditions would make situation worse, so make a person more vulnerable. So we look into the disease prevalence. But at that time, we also saw that, as a demographer, so you have a age and then you have the sex, like what Thomas was mentioning, that the more males were getting kind of the fertility rate were higher for males then. So we thought, okay, let's also have a look at the sex ratio. So again, with our projections, we could see like what is the sex ratio at the different, at the district level. And we identified like 115 districts where there were a lot of males. And then we move on, including the comorbidity. So again, we had this data from the National Sample Survey, which can tell us at the district level what are the prevalence of the important diseases or the conditions like cardiovascular conditions, problems with hypertension and diabetes and respiratory diseases. So we took that data from the survey and tried to estimate that at the district level. So we have age, we have a proportion of males, we have cardiovascular, the disease prevalence. And we tried to estimate the age sex specific prevalence at the state level. So it was not always available, in terms of the detailed age groups, but whatever was available, we used it. And then we kept on like updating our map of vulnerability. And so again, so this map kind of tells us, this map is purely about the prevalence of those comorbid diseases, and one can identify those areas, again, mostly these places, urban areas where there are lots of people, older people there because of the life expectancy, a better life expectancy or better mortality conditions in urban areas. So next, so it's the thing that we are talking about are the individual characteristics. Now we move to the household conditions. So this was also a surprise for me that in India, in average, there were 3 persons per sleeping room. So that means this is the close contact within the household, right? And then there is this, the way the people live in India and also in Nepal, in South Asia is this combined family. So it's not a nuclear family and combined family. So there's lots of interaction at the between the young and the old people. So we thought that this is an important indicator that we should consider, like how crowded the house is. So again, from a different survey, we estimated those numbers. So the household, we call it household congestion ratio, like persons per sleeping room, and we brought this into our calculations. So this kind of gives you an idea about the household conditions in India, and you see that in earlier maps, in terms of age and the cardiovascular other comorbidities, these areas in the northern kind of India were not so prominent, but the household condition ratio is more associated with poverty and all those things, and so those areas where there were problems with poverty, but also in urban areas, because that it's expensive to have more bigger houses and bigger rooms. So this kind of tells us that that poorer areas have poorer areas are more vulnerable in that particular dimensions. And the next one we identified was, okay, so you have a household. So in the household, so the sanitation, the water, sanitation, and hygiene is a very important part here. That you need to wash hands, right? So this is what we have been, what is very important to fight against COVID. And so again, this variable we looked at, like for India, just to give you a number, there is 48.2% coverage with basic sanitation. So at that time, this is from 2015-16 survey from 2015-16, and so more than 50% of the household do not have a basic sanitation. So this was also very important variable. So we included that in, and again estimated it at the district level. I mean, all the details about where the data was not complete, or at sometimes some places we could only estimate at the state level and then had to bring it down. So there are lots of issues about that, but we try to use data that is publicly available, all the information that is publicly available. So this was another variable, and here we have like three sets of variables. So the drinking water, hand washing. So in terms of hand washing, it's like, do you have a facility of hand washing within the household, and whether the soaps are available, are where in that area of hand washing and all. So we did this, and finally we brought the education attainment and media exposure, like the information that you are getting from outside, like what to do, how to prepare yourself, how to save yourself from from getting infected. So we thought that knowing the educational level of the community, so we could do it at the household level as well, but we looked at the community level and defined like what is the level of educational attainment at the community level, at the district level. But also we looked at the media exposure, like I think it was done in terms of mobile phones and television. So we put all of them together. We tried to think about different ways of putting them as one index. I was more thinking that maybe we can just leave it like having a 4-dimensional index or even 5-dimensional index. But at the end we decided, okay, let's just put. I mean, we have provided all those data in our working paper, but that was updated when we submitted it to +1. So for the moment, we used the equal weights for all of these, and use a simple method that the UNDP uses to calculate the HDI index, and then define this COVID-19 vulnerability index for India. We did this, and then we submitted it to the +1. Our paper were also in this archive, medical archive thing. And our Indian colleagues, well, since I'm not an Indian, I'm living not in India, so our Indian colleagues were internally providing this information to different places inside the country. Sometimes they ask for the population, or sometimes they ask for this and that. So I think they were quite active, especially Rakesh Misra was quite active in providing lots of information to different places, to the ministries and all. So other than that, I think we didn't manage to publish this. And so at the moment, what we are thinking is we would then publish it in the, we will write a new paper where we actually take, because many others have also produced this kind of work, but we think we have some specific thing, especially the projections and all those. We are kind of unique, and so I have lots of other things I could tell here about the recommendations and this and that, but I think I stop here and then let Guillaume get some questions. Thank you.
Thank you, Samir. We don't have much time for questions. So before taking questions from participants, maybe I will give the opportunities to the presenter, to the speaker, if they want to ask questions to other presenter or comments. So please unmute maybe. Jennifer, you have, yes, go.
Sure, if I can ask one quick question of Enrique. But also just thank you all there for putting together that amazing resource. There was a big lack of data early on, so it's been really helpful. I was super curious about the Germany excess mortality data that you showed, because I had just shown how it looked like in one way that German official mortality looked as high as the UK and the US. So is there something that you know is going on there where they do seem to be overcounting official COVID deaths? Because it seems hard to believe they could just have compensation of lower deaths and other causes that would be that severe to account for that big of a difference.
Yeah, thank you for the comments. It's not that it's not that there is no excess mortality. There is excess mortality, but the excess is lower than the confirmed deaths. Yeah. And that's a very good question. I'm intrigued also, because there is a similar pattern in other countries. I think Canada, I was also looking at it, and it's the same situation there. And at least in Canada, I was suspecting that it was maybe, in Canada, the particularity, as in other European countries, is the concentration of mortality in the long-term care homes. Mm-hmm. And maybe this concentration of mortality among very vulnerable groups could produce this harvesting effect or this compensation. But I think that is not the case in Germany. Okay. So one possible hypothesis is maybe a better job in testing and a better job in identifying mortality. Yeah.
Okay. Interesting.
Okay. Other questions? Tamas, you?
Yes, I wanted to follow up a little bit on Jennifer's question to Enrique. Thank you, Enrique, for discussing the database. I had essentially two things. One was the same as Jennifer about German data. And the amazing thing about German data is that this disparity between excess mortality and reported COVID mortality is not highest at younger ages, where I would expect that there could be fewer deaths because people are locked down at home and don't drive crazy on the highway. It was highest around age 75, when the excess mortality was reaching about just 10% of the reported COVID mortality, which is very difficult to explain. Why would people around age 75 die much less than the COVID death statistics would suggest? So I think it's still a puzzle. Maybe you have some more explanations of that. And the other question was about the second paper you presented, about the one with Christian Dudel. I think the efforts to estimate the number of cases from excess mortality rates is very useful, and I've seen some other papers as well. But I think when it's done by age, it's very tricky at younger ages, because very small COVID fatality rate at that age. And then the sensitivity of these estimates is really, I think it's difficult. So if I would do this by age, I would start at age 50 or 60. I would completely ignore younger ages. You have quite some irregularities at some countries. I think at younger ages with very few COVID deaths, it's difficult to make an estimate of cases from deaths.
Thank you, Thomas. Thank you very much. I agree with you. The case of Germany, yeah, I think it worth to look again at the fitting of the baseline and look more carefully what is the difference by age, of course. I presented the most basic model that we were using. Now we had the good news that Jonas Scholli from Southern Denmark University is going to join also the Max Planck and also will bring a lot of different estimates of excess mortality, because I think one important thing, and the excess mortality is, the baseline fitting is very controversial, and there are it's very sensitive to the splines and what weeks to account and what not. And he has been working in that, comparing more than 10 different models. So our idea is to make this available, every estimation, and also make available the code so people also can bring and create an open discussion about this. Regarding the second part, I agree with you, and even my slide this morning was, as you said, starting from 50 over, and I say, okay, now let's show the thing, even if it's highly fluctuating. And I think you were right. The infection fatality rate, it's very low in younger ages, and even looking at the Spanish serological study, there are several ages in which the infection fatality rate is 0, which is impossible. And the other aspect is also mortality is so low at these ages that it can just jump and fluctuates. It's very shaky, the estimate. So yeah, I agree with you. Maybe the best to do when scaling this kind of infections is start at ages maybe 50 and older or something like that, or 40. I don't know. But thank you very much. I appreciate it.
Thanks.
Thank you. So maybe, so for those who have questions, I will ask you to write it in the chat, and I will read the questions then. So if you have, please just go as you wish. Or while you are writing, maybe I can ask myself questions. Oh, it's a general question, so any of you can reply maybe. I was wondering if the age-specific fatality rates differ a lot among countries or among regions or over time, or if you have any evidence of big difference among countries, or if it's always about the same.
I can speak a little bit. Again, I think it's been hard to get really good data, but as I mentioned, it's been noticeable that in the US compared to the UK, age-specific fatalities have been higher in sort of the middle ages, between 50 and 65 in the US. And my understanding is Latin America has seen much higher risk in sort of the middle ages as well compared to European countries. But someone else might have some other examples.
I will also jump in, and I think the big limitation to answer that question is the lack of information in countries with very different health profiles. And most of the data that we have now is for Western Europe and the US. Regarding both good quality of mortality estimations, but also serological service with national representative samples. But as Jennifer just said, I think looking at Mexico or these kind of countries, you can see very different age patterns that of course are affected by the age distribution of the population, but still there is a huge difference that can be maybe explained by the prevalence of comorbidities and sanitary conditions, etc. But I think it's a very tricky question, and we need much more data to grasp that.
So, which means that what you suggest by estimating the real infection rate by using the deaths and the infection fatality rates, if the infection fatality rates differ among countries, it's not like a circular calculation eventually that we don't know exactly. So which one is the true, the real accurate data?
Yeah, that's a good question, and that's very arbitrary, the selection. So looking at that again, our intention is also to publish as many as possible serological surveys, so people can also select different approaches. I choose in this case this Spaniard one because I think it's one of the most comprehensive. Is nationally representative, even at the provincial level. So we can also look at the provincial level, and also because in the method that was proposed by Bock, Ewald, and colleagues, you can extrapolate that adjusting by difference in health profiles, and that is the advantage of taking one country. If you look at other infection fatality rates specific by age that have been proposed by, for example, I think Odrisco, and there are other like nice papers doing meta-analysis. The problem is that you have so many countries involved that for making the mapping to other population would be very hard. So yeah, I think there is a lot of things to develop on it. I think we are just starting to propose things that can make sense of that. But I agree with you. There is a lot of challenges there.
Guillaume, I think you were hitting with your question at something we still don't know much, and it's amazing that we are almost 1 year into the pandemic, and we don't know much about cross-country differences in infection fatality rates. And often the models we are doing are based on just 1 or 2 estimates, which we believe are credible, like Enrique working with Spanish data. In the initial stage of the pandemic, people were often working with Chinese data. There was one set of Chinese data of fatality rate by sex and age, which has been used and replicated in many studies. But it's very, very plausible that these are different between countries because health systems differ. The accessibility to healthcare differs. Also, in different stages of pandemic now, the healthcare systems are overwhelmed in many countries. So not all patients can be treated properly. In Belgium in spring, people were not being transferred from care homes. They were dying in care homes because hospitals didn't have capacity to take them. So it's very, very likely that this all affects infection fatality rates in different countries. And I think we need to do much more to really find out how much difference this makes even among the highly developed countries, not even thinking of countries with much less developed healthcare systems in Latin America and in Africa.
Right. Okay, so well, if no one else has questions, now I see one in the chat. Okay. So Asfara Hossein Imal raised a question. In overall study of all, what is the overview about males and female death rates in COVID-19? Are they males death rates higher or female? I think it's really more for you, Tomasz, these questions. It's a concern gender differential.
I think Jennifer will probably know more because she's studying mortality more than I do, but the overwhelming evidence is that men at any age have higher fatality rates than females once catching COVID-19. Probably there are differences between countries, but the differences can be up to the magnitude in up to twice higher death rates among male or fatality rates among males than females. If we looked at it early in spring with the Spanish data and data for some other countries, when I say the biggest difference we found was that based on the reported data in spring, males in their 70s in Spain had the same likelihood of dying of COVID once contracting it as females in their 80s. So it made a difference like 10 years of age in their likelihood of dying.
No, I think that's exactly right from the data I've seen. And I think it'd be interesting to look more closely at how that compares to normal sex differentials in mortality at older ages. I don't think it's that different. And then there's been some interesting papers by immunologists looking at specific immune responses in older adults by sex and seeing some significant differences to try to explain that. But I think it is interesting to look at it in the lens of the overall sex differences in mortality that we're familiar with. So, but it is quite strong. And so I've never heard that come up in these issues of shielding the vulnerable or vaccine prioritization. So it's kind of interesting that no one mentions that very often as a high risk factor, but it is really important.
Thank you. We have another question for Samir this time from Sunatra, asking, have you tried CVI for other countries or only for India?
No, because in order to do that, we really need a local partner. Yeah. So if anybody wants to work with us, yeah, that would be more than welcome. Thank you, Sunetra.
Sammy, thank you very much. It's very interesting. So what about, have you tried the Nepal situation, Sammy? Would you
in Nepal,
have any idea for the Nepal situation also with CVI? I mean,
we didn't estimate CVI for Nepal as well. Yeah, we did something at the beginning, but not in the details that we did. Again, I couldn't find the partners in Nepal. They were all they are busy in their own things. Yeah. Thank you.
So you have collected data via the Google or the online survey or
these are all these are all existing surveys like the DHS and the National Sample Surveys in India. So it's like whatever data is available there, we use that. We didn't do any data collection from outside. Yeah.
Okay, thank you very much.
Thank you. So we exceed already the time. So well, I will close maybe this webinar. I think it was very interesting, and I hope next time we can gather in persons. Maybe next year. I hope it will be finished, and yeah. So thank you everyone for joining, and thank you in particular for the speaker to give her time and present this very interesting outcome on COVID-19. And
thanks everybody.
Thank
you very much.
Thank you.
Thank you. Bye-bye.
Goodbye.
Bye-bye.
It was really a nice session. Thank you so much, everyone.
Thank you.
Thank you.
Thank you. Thank you so much. Bye-bye.
Bye-bye. Okay. Bye-bye.
Bye.
Okay.
bye.
Bye, guys.